תודה רבה, נועה. שלום, סלאם. סליחה, אני לא מדבר עברית, so I will continue in English, and I hope you will be able to understand. If the Pope was actually here, he might say, and I'm thinking he might say, invest well in all your infants and all your children. Watch them grow and reap the benefits for future generations. But he didn't say that. I hope he would, not yet. But I'd like to first of all thank Noah very much indeed, and thank Anat, who's been hosting me. Thank you for organizing this. I want to thank Itzik, who I think, although I just met him yesterday, feels very much like a soulmate, a soul brother. And I'm very impressed with what is happening here in Israel. And I'd particularly like to thank Mary Rudolph, Professor Mary Rudolph, who has been instrumental in linking me to this wonderful organization. So thank you for that. So I'm going to stand here so that I can move around a little. I'm going to start with this picture. And interestingly enough, I saw in Greg's excellent article exactly the same words. We're all in this together. I hadn't seen that before when I'd made up the presentation. And what I'm going to do in my talk is just to outline some of the changes in the epidemiology of children, look at some of the new insights, the new scientific insights around life course epidemiology and neurobiology, and how those can be brought into a clinical program and a public health policy for children. I'm going to explore how that has happened in different countries and share some of the experience of this type of program in different countries, and finally finish with some challenges and themes for Israel. We have succeeded over the last 100 years to make a very, very big impact on children's survival. We have been able to reduce the mortality rate from the biggest killers in the 19th century. However, through immunization and sanitation and nutrition, we're now left with what is often termed as the new morbidities. Not so new, but they are morbidities that are impacting and we are seeing as professionals on a day-to-day basis. So although we've succeeded in reducing, for example, communicable disease due to infection, when our eye is off the ball, polio can return, as it has done in this country. So we have to be very, very careful to maintain a very high rate of immunization. We have succeeded worldwide to some degree in reducing injuries, but instead we now have increased numbers of babies with low birth weight and prematurity, about 10% on average increase in the last 20 years in most European countries, an increase in children with overweight and obesity, around 5% increase in neurological and developmental disorders, and a very high increase in mental health problems and also cancer. So these are the challenges that all of us are facing. If you think about preventive healthcare systems, they were based on a very simple idea that a single cause would find a single outcome. So if you think about infection, you have germs, and if you kill the germs or prevent the germs coming in, then you have reduced infection. For the new morbidities, we have a much more complex causal web. And there has been much more attention to looking at the way in which social factors interface with individual and lifestyle factors and genetic factors to create these diseases and challenges that we see today. And what you see in this diagram, which is very familiar to many of you, is the notion of concentric circles of influence from the individual child and family to the lifestyle of that family, to the networks and social setting of that family, and of course to all the things that impact, whether it's housing, healthcare, water and sanitation, employment levels, the education level of the family, agriculture and food production. And all of us have been affected by this massive recession. Certainly in Europe, this has been a very major impact on our children and our parents. So what insights can we gain from two of the most recent scientific areas of development? Life course epidemiology and neurobiology. I showed this slide to Noah because I think it was very interesting for her to be aware. She said she wasn't aware of this data, which is showing the risk of coronary artery disease in middle-aged men related to the birth weight, their birth weight. This is in pounds because in the UK, in England, the children were being measured in pounds. But the greater the birth weight, the lower the risk, the standardized mortality ratio, was for coronary artery disease. So people are asking the question, what is it that is happening when you're making a baby that might be affecting the later risk of adult disease? This whole approach, which is now about 25 years, is around looking at the long-term effects of later health and disease risk related to the risk of exposures during gestation, childhood, adolescence, and young adulthood. Neil Halfon, who is a very influential philosopher and thinker, a pediatrician and public health specialist, talks about life course health development as an adaptive process that builds and maintains optimal functional capacity and disease resistance. In other words, what can we do with our families that will build up resistance, will build up assets that can protect you for lifelong health? So essentially, if you had to simplify the idea, you're born, things happen to you along the way, good and bad things, and eventually, you change and you die. The interesting thing is how the impact in that very early period, of life has a disproportionate effect, potentially, on your trajectory. Let us apply this idea to the developing brain. This picture here shows how fast the brain develops from the early weeks of gestation to the newborn period. This massive increase in brain development. And if you think about the environment that that brain is actually growing in, one can see the impact that exposures in pregnancy can have. Many of you will have recognize this slide. I wonder if I could just take a show of hands of people who've seen a slide like this. So this is, if we had shown this 10 years ago, people would not be that familiar with this idea, which is essentially that these are some nerve cells here at birth in the brain, and you can see how the nerve cells have overproduced by about age 6 and then are pruned back depending on experience. They are cut back like a tree depending on the experience you have. So the first few years of life are critical to the developing of the tree, the developing of the connections in the brain. So whether it is to do with your vision, whether it is to do with your hearing, whether it is to do with your ways of responding in language terms, or it is the way of, whether it is to do with your emotional control, all of these aspects of development have a very important sensitive period around the first 2 or 3 years of life. So the story that is emerging is of the importance of investing sufficiently early to influence the trajectories for this development. So the first 2 or 3 years are absolutely critical for neurodevelopment for the child. The same scientific discoveries have now been shown in adolescence, and there is another critical window around the ages of 14 to 20, 22. So there is another very critical window of very fast brain growth. So those 2 critical windows are the ones in which we can influence future health most. So let's go back to the baby. What are the factors that influence the nervous development in the baby? Well, the genes, clearly. Oxygen and blood supply to the brain become very important. And so the health of the pregnancy itself obviously affects the brain. The nutrients that affect the brain particularly are iron, vitamin D, and zinc. And the physical environment, whether you're exposed to toxins in pregnancy or poor water or foods, make a very big difference on development, and as does, and as you well know, socio-emotional environment. How does the social-emotional environment in pregnancy really affect the baby's brain? Well, if we look at some of the factors that I showed you in the previous slide, and some of you may recognize the effects of fetal alcohol on the baby, or of the lack of folate in the nutrition of the infant, creating spina bifida, or a difficult birth that leads to bleeding in the head and hydrocephalus, or a difficult antenatal period, a poor pregnancy which leads to cerebral palsy. So these become very high-risk infants for later care. If we look at some of the issues around socio-emotional development, and we look at some of the animal studies that have been done, and we take the adult mother rat, and we look at the mother who has been separated herself at birth, or has been poorly handled by her mother in turn, or not handled, we see 3 patterns which become very important for her baby. This graph shows levels of stress hormone called ACTH related to the restraint of the babies, the pups, of those mothers. And what you can see here is if you have, that mother had maternal separation very early herself, the stress levels in her own pups are actually very high indeed. These levels of cortisol are high. However, if the mother has been well looked after herself and has been handled well, that this degree of stress in the pup does not create a level of stress hormone as is shown here. So we are learning a lot about the biochemistry of the brain and its relationship to later stress levels. When the stress is particularly toxic, you can see that even in the first 3 years of life, you will see a difference in the growth of the brain from toxic stress, very high levels of stress and neglect. If we return to other aspects of the environment and we think about language for a minute, and we think about the child's age, and we think about the number of words that the child develops, this varies according to the environment that they are living in. So that for the most educated parents, it feels obvious for you, to this audience perhaps, but what I think is so striking is that there is such a difference at the age of 3, depending on which type of family you are brought up in and what type of language environment is occurring in that family. This slide shows, and this is taken from Neil Halfon's work in Los Angeles, shows 3 different trajectories in the first 5 years of life. A healthy trajectory in green, an at-risk trajectory in yellow, and a delayed or disordered trajectory in red. And what you can see here is the factors that push those trajectories downward, and one of them was the toxic stress that we were talking about, a very stressful life environment, difficult housing, drug and alcohol abuse, domestic violence. These would be toxic stressors on the child, pushing his trajectory down. If you had poor health services or very high levels of poverty, you are clearly pushing this trajectory down. However, you can protect and you can prevent some of the effects through parent education and emotional health literacy. Very good studies showing reading to children at a very early age, even below this age, has a big difference on the ability to be school ready, appropriate discipline in the family, good quality health services, and in particular, high quality preschool. And I know Greg will be talking about that later. Itzik talked about the importance of investing early in childhood. We need to invest extremely early in pregnancy and infancy if we're going to return the investment in the future. Nobel Prize winners, economists have shown the evidence base is strongest in the early years for cumulative, but public investment tends to be much later. So optimal investment is really in pregnancy in the first years of life. What happens if you don't do it? If you do not invest, and the UK is shown here amongst 16 countries, showing here the comparative costs of social problems in 16 European countries. And you will see the UK comes out at £161 billion are the costs estimated in the UK compared to these other countries. If we look at the spend, and this is in the article that's in your booklet, you will see that we spend, and we start from the bottom here, over 300,000 sterling pounds on the criminal justice system per child. 264 million pounds on children in the criminal justice system. Social care, around £5,000 pounds per child. But if you look at the health service costs and you look at the preventive care costs, these equate to about £40 per child. And there is good evidence that a better investment in these two areas, both universal and targeted, may well reduce quite considerably those children that end up in the criminal justice system. Our government in England, in the UK, has taken this sort of spend very seriously, and the Treasury had started in 2007 to place a lot more emphasis on investment in early childhood centres and programs to try and address some of this. It's still not enough. So that brings me to the concept of two ways in which we can develop strategies for prevention. And this is based on work from an epidemiologist called Geoffrey Rose in the UK, and in relation to high blood pressure. So what are the strategies for prevention of high blood pressure? You can either pick out the high-risk people, people who are obese, people who have a family history of high blood pressure. You might screen them in the community, and you might treat them with drugs, or you might monitor their blood pressure very intensively. Or you can actually take that's a high-risk strategy, or you can take a universal strategy for reducing the levels of high blood pressure in the whole population by, for instance, reducing the salt levels in foods. So you have two different strategies, a high-risk strategy and a universal strategy. We spend a lot of time identifying and managing the high-risk group of children with developmental disorders. And that is right. We need to do that. And JDC Ashalim is very instrumental in investing in programs that highlight this high-risk group. However, the effort devoted to reducing the risk amongst the entire population has a very large effect, potentially, if effective. And that is the universal strategy. So what we need, essentially, is to have both. We need to have both high-risk strategies and focused on children with developmental concerns and risks, and a low-risk strategy or high population level a strategy that changes the risk for the whole population. If you look at this graph here, this shows low-income families, median-income families, and in green, high-income families related to vulnerability. And there is a disproportionate number of disabled and long-standing illness group of children in the poorer sectors of our community. We spend a lot of time on clinical and individual interventions in this group, and we try by early detection to move them along to the to improve their vulnerability. Targeted interventions tend to be in this area. However, there is another strategy, which is to shift that curve completely to the right, so that actually the parenting skills for the whole population, the safety of the whole population is altered, and that curve actually shifts to the right. There is occasionally, and this has been shown, that if you do this very well, there is a danger that you may actually increase inequalities, and so it is very important that we are mindful of that, challenge. So particularly ensuring that low-income families also get shifted across becomes a vital priority. So how do we actually deliver such a concept. I've talked about the success we've had in immunization and in screening to some degree, in growth monitoring, in nutrition. I've talked about how the new morbidities have really hit us in terms of mental health problems, neurodisability and developmental issues. I've talked about how the new sciences have led to new program development and the importance of universal and targeted services. How do we now translate that into practice? So I want to give you 4 examples. In 2009, the professional group of maternal and child health, of midwives, of dietitians, of general practitioners, of community nurses, brought together a consensus from the evidence base and said this is the program that should occur across the whole country for all children. We approached the government at the time, and we had a champion in that government, a pediatrician working with the Department of Health, who, together with the Department of Education, developed this policy program, the Healthy Child Program. If I look at the outcomes that are expected of this program, they are listed here. We want strong attachment, positive parenting, improved social and emotional well-being, improved safety, improved breastfeeding, healthy nutrition and physical activity, high immunization rates, readiness for school, early recognition of problems and risk factors for obesity, and early recognition where development is not taking place well. If we all align ourselves to those outcomes, and that's what we must do and must measure, this would be a very important statement. And we have this program, which is a combination of screening tests, parenting support, immunization, and periodic health reviews, led by the health visitors, our community nurses, our public health nurses. And that program is delivered from a universal base. The difference is that we have, in this policy, we have this concept that for those children with additional needs, we basically increase the amount of support so that we have 3 levels of support. I mean, there are really multiple levels of support, but we've given it in this document 3 levels of progressive support depending on the risk levels of the individual families. So at the very high end, which a lot of JDC Ashalim programs are intensive, referral for specialist input, action to safeguard children, care packages by specialists, we have also a seamless movement between these 3 programs, this progressive universalist approach. This is supported by a standard set of e-learning tools which are given to all staff, which are accessible to all staff on these issues. If we look at Sweden, we see high quality and comprehensive prenatal and postnatal care. There is a financial policy to reduce child poverty levels, and although they don't give cash transfers as they do in Mexico and Sweden, there is definitely a very strong financial support for parental leave, monthly nurse visits, and universal access to high-quality, graduate-led preschool provision, about 80 to 90% of preschool. And play-based development with transition to formal schooling. What about Cuba? You might argue that Sweden is a very rich country. We don't think we can do this. Well, Cuba is a very poor country. But they have successfully, very successfully, had a very strong universal program with a fully, it's called Educar a tu Hijo, and it is a fully integrated program of family-centered health and education with social organization support, with multiple visits, antenatal checks, and at least 1 or 2 developmental stimulation sessions per week for all children. 87% of children reach school ready for school. We cannot say the same in the USA or the UK. That is a poor country investing in a universal service. 4 years ago, I understand Professor Oberklade came to speak to you about the Platforms program, and he talked about raising awareness, community engagement, implementation, monitoring, and evaluation. I've seen in the last 2 days exactly how you are doing this in your children's centers, your child units, and I'm seeing how you measure and map, not necessarily using the same technique as was done in Australia. They use the AEDI tool. It's a measurement tool looking at physical health, social competence, emotional maturity, language and communication skills. And you've seen this type of maps. I think he showed you this type of map before. So there's a map of disadvantage in a locality in Melbourne, in Australia, with the most disadvantaged in the dark green and the least disadvantaged in the lighter colors. And you see the children, the percentage of children who are vulnerable with 2 or more of those domains in those areas. And that measurement tool has been the way in which data has been fed back to the community in order to make changes to the community programs. So they obtain a comprehensive picture of early childhood, they plan actions to improve outcomes, they implement strategies to improve childhood, and then they repeat the cycle. It's exactly what Greg's going to be talking about: plan, do, study, act in cycles with our communities. He also spoke of the universal and specialist services being much more closely connected. And again, in the article that I wrote in this, in your journal, you will see a diagram very similar to this that shows the importance of having specialists working across these boundaries. It has immense value for those that are working in the universal services. It helps to improve referrals and helps to improve knowledge of those working in the field. So I finish with a number of themes emerging. The theme that I think is that many of us around the world are sharing a vision of investment in early childhood years. This requires great leadership and trust in the community and trust with each other. I have noticed over the years that there is now a much better shared language between the scientists, between the social scientists, between the psychologists, about the ecology of children's health and well-being, and a shared culture that is moving from a seek and treat paradigm, where we hunt out those children with problems and treat them, to a prevention and promotion paradigm, which actually is based in children's rights and advocacy, and in empowering the community to look after themselves. A shared system of monitoring outcomes and accountability, and integration of services at all levels. Above all, and I think this is probably the most important thing, is a sustained political commitment from those in the ministries, from those in government, and a willingness to experiment and to take evidence-based programs and support for early investment. That's the fun of working in early years. And that is what we are trying to deliver. For every woman and every child, we will advance a better life for people around the world. Thank you.